Next, we have Adam Badavia from University High, and his mentors were Dr. Srila Misra, she's here on the podium, and myself from the Department of Endocrinology, UCSF Fresno. And Adam is going to talk about Kerendia use in chronic kidney disease and type 2 diabetic patients, and this is a quality improvement analysis. And to us, to the Department of Endocrinology, Adam means it's brain, hard work, and perseverance. So I welcome Adam to the podium.
Hello, everyone. My name is Adam Badawia. I'm a rising senior at University High School, and my project is a quality improvement analysis on the prescription of a medicine called Kerendia. So let's start off with the environment. I did this project at an outpatient clinic, the Inspire Health Medical Group Endocrinology, and the project was done under the leadership of Dr. Babu, who you just met, and Dr. Mishra, who's the program director of the Endocrine Fellowship, and the data analysis was done by Dr. Del Rosso, who is the program director of the Sleep Medicine Fellowship. So here's some background for my project. Diabetes mellitus is a medical condition where the body doesn't produce enough insulin, which is type 1 diabetes, or it doesn't respond normally to insulin, or it builds up a resistance, which is type 2 diabetes. Type 2 accounts for about 90% of total cases, and it's what we're mainly going to be focusing on for my project. And diabetes is heavily prevalent across the entire United States. 14.7 people have diabetes according to the CDC, and that's diagnosed and undiagnosed. And it's more especially heavily prevalent in the Valley, where rates are higher than the rest of California. And when diabetes goes uncontrolled, blood pressure and blood sugar can go really high, and that can lead to a bunch of complications like retina damage, nerve damage, and damage to your blood vessels, which can cause heart problems, heart disease, as well as kidney problems, like diabetic chronic kidney disease, which we'll call diabetic CKD, where the kidneys don't work as well as they should, as well as proteinuria, where the kidneys don't work as well as they should, and there's a bunch of protein in your urine. And now Kerendia, which is the brand name for Finerenone. It's the main focus of my project, and it's a drug given to treat comorbid type 2 diabetes, chronic kidney disease, and proteinuria. And it intends to slow the progression of chronic diabetes, chronic CKD, as well as proteinuria. And it also intends to lower the risk of adverse heart problems like heart attacks and heart failure. So as you can see, as a demographic gets older, the total diabetes percentage within that demographic goes higher, with 30% of those above 65 having diabetes. So it's a huge problem. So here's some more information about Kerendia, which is the brand name for Finerenone. It belongs to a class of drugs called mineralocorticoid receptor antagonists, MRAs, which help lower blood pressure, and they basically help with your heart and reduce cardiovascular mortality. And there's two main types, steroid-based, like spironolactone and eplerenone, and non-steroid-based, which is Finerenone, Kerendia. And we find with non-steroid-based, they have a lot more benefits and less adverse side effects like gynecomastia and hormone problems. And they're also a lot newer. They're FDA approved in just 2021. So with the emergence of this new medicine, the American Diabetes Association, the ADA, put out guidelines for when to prescribe Kerendia. And they recommend prescribing this medicine when patients exhibit all of the following. Diabetic CKD, so that's when the estimated glomerular filtration rate, the eGFR, is between 25 and 60. That basically measures how well your kidneys work, and the normal range is 90 to 120, as well as patients who have proteinuria. So that's when the urine albumin to creatinine ratio is greater than or equal to 30, as well as patients who have normal serum potassium, which is when the blood potassium is less than or equal to 4.8. So when patients have all those problems, despite taking the maximum tolerated dose of renin-angiotensin-aldosterone system inhibitors, RAS inhibitors, the first-line treatment for diabetic CKD. So if they have all those problems, despite taking this medicine first, then the ADA recommends that that patient be put on Kerendia. So here's the actual wording that the ADA puts out. They say cardiovascular risk and mortality is reduced when patients are put on non-steroidal MRAs, which is Kerendia, and also when the eGFR is above 25. And I'll get to why in a second. Same thing on the bottom here. So with the high prevalence of diabetes in the US, and especially in our valley, the high rates of kidney problems and complications, as well as the emergence of this new medicine that just came out in 2021 that physicians might not be too knowledgeable about, We were inspired to start the study to assess how often patients with chronic kidney disease, proteinuria, and normal serum potassium were prescribed Kerendia according to the ADA guidelines in our outpatient clinic. So that's basically our research question. And our project is a quality improvement, and it kind of follows this framework. So first, I evaluated how many patients currently met the guidelines for receiving Kerendia. And second, I determined what percentage of those eligible people were put on Kerendia and also what other medicines that they were put on. And then third, I used my findings to motivate an intervention stage, right? Educated and informed providers about the guidelines and when to provide Kerendia. And then fourth and finally, we'll reassess if the patients meet the guidelines and what medicines that they were put on and compare it back to the baseline and assess our improvement. And hopefully it's a big number of improvement. So to start off, here are our methods. I did a retrospective chart review through Epic. So that basically means I looked at all the visits to our clinic, and then I looked at each person's chart and looked at if they fit the criteria for getting Kerendia and if they received it. And I used these inclusion and exclusion criteria to do that. I included patients into the data who had diabetic CKD, type 1 or type 2, and or proteinuria, and always serum potassium less than or equal to 4.8. And then I excluded any patients who had end-stage renal disease, which is kidney failure, hyperkalemia, which is high blood potassium, kidney transplant if they were minor, or if they had non-diabetic chronic kidney disease. So those people were out, the people on the left were in. And here's an example of my data table that I used. I put the demographic information, their diagnoses, and as well as the different medicines that they were put on. And this data was analyzed, and then here are the results of what we got. So out of about 31,000 total visits to the outpatient clinic, I looked at about 500 charts, and then I included 186 as having fit the criteria, and we included and analyzed those. So some demographics, 42% of the people were female, and the average age was 70.6 years old. Out of 186 participants, 35 had only proteinuria, 76 had only chronic kidney disease, and 75 people had both. So that's around 19%, 41%, and 40% respectively. So RAS inhibitors, as I mentioned before, this is the first-line treatment for diabetic CKD. It's a renin-angiotensin-aldosterone system inhibitor, and there's two main types. Angiotensin receptor blockers, ARBs, and angiotensin-converting enzyme inhibitors, which are ACE inhibitors. They both work by reducing the action of angiotensin, which is a hormone that increases your blood pressure. So that has the net effect of lowering your blood pressure and helping your kidneys and heart. It's a really great medication, and it's the most common first line for diabetic CKD, as well as for heart disease. So out of 186 people, 135 were on an ACE inhibitor or an ARB, and 51 were not on either. So that's 72.6% versus 27.4%. And out of 135 people on this medicine, 46 were on the maximum dose. So that's the highest dose that you can get. So that's around 24.7 people. So now the second medicine, SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, it's another common first-line medication for diabetic CKD, and it works by preventing glucose reuptake through the kidneys, and it has a lot of good effects on your kidneys and heart and blood sugar. And out of 186 people, 99 were on these SGLT2 inhibitors, and 87 were not. So that's 53% to, what was that, 46%. And finally, we have Kerendia. This is the main medicine we're focusing on. And it's a non-steroidal MRA, and it works by blocking the activation of hormones like aldosterone, which increase your blood pressure, again, for the net effect of lowering your blood pressure and helping out your kidneys and heart. It reduces inflammation and fibrosis of the kidneys and heart. And it also is a second-line treatment after the maximum dose of RAS inhibitors. And out of 186 people, 11 were on Kerendia, and then 175 were not. So that's only 6% as compared to 94% of people who are not on Kerendia. And I expected less people to be on Kerendia because it's a second-line treatment. As you can see, the first line would be SGLT2 inhibitors and RAS inhibitors on the top, and then you can see non-steroidal MRAs in the middle when the symptoms of proteinuria and CKD persist. But that number is super low, and I'll get to why in a second. So first, here's some strengths and limitations of my project. Some strengths, it was a large academic center. There was like 31,000 total visits, but some limitations where it was only one outpatient clinic, and it was a single database. So a person might have received a prescription outside of the Epic charting system, and we wouldn't know about it. But here are our conclusions. Out of 186 eligible participants who could receive Kerendia, 135 were on a RAS inhibitor, which is 73%, 99 were on an SGLT2 inhibitor, which is 53%, and 11 were on Kerendia, which is only 6%, which is super low. 41 people were on a maximum dose of RAS inhibitors, but were not put on Kerendia. That's 22% of people whose next stage of treatment should be receiving Kerendia, but they weren't getting it. And even more people could only tolerate less than the maximum dose and should be getting Kerendia. So clearly there's a big problem. And there could be a lot of reasons for this, like insurance problems, adverse reactions to the medication, or maybe just a physician's lack of knowledge about the guidelines and when to prescribe it correctly. But however way you put it, there's a huge gap between the standard of care and our practice, and ADA guidelines were not being fully met when prescribing this medicine. So this motivated me to do an intervention stage to achieve the best renal and cardiovascular outcomes. And what I did was I educated providers on the proper guidelines using the results of this very project. And I also created quick reference materials for providers to look at with all the dosing information, benefits, side effects, and the guidelines for prescribing Kerendia. We're going to put these up in the offices just as a reminder for the providers. And there you can see it on the right side. It's very beautiful. And then some future directions. In 3 to 6 months, we'll reanalyze what patients are eligible for Kerendia and what they were actually put on. And then we'll compare it to the baseline. And we aim to find a 20 to 30% improvement in prescribing Kerendia, as well as better kidney and heart function in our valley. And maybe everyone's kidneys can finally be happy. So in conclusion, I'd like to thank my mentors, Dr. Babu and Dr. Mishra, for their guidance, Dr. Del Rosso for running the statistics, and Tiffany Robinson to her commitment to running the SBI program. And I'd also like to thank all of you for watching.
That was phenomenal as expected, Adam. So I should say this project is moving on to the next phase because he did a wonderful, wonderful study with us. And actually our endocrinology fellows are actually taking over the next part of the project. And I really thank him for his hard work. Now, next